afternoon, and welcome to our Infectious Disease Grand Rounds. There is no commercial support for today's program. The speaker and planners have disclosed no relevant financial relationships with commercial interest. If you have a question for the presenters today, please hold until the Q&A segment at the end of the talk, and you can add that question into the Q&A section. Link to the event survey will be shared at the end of the program. It is my pleasure to introduce our guest speakers, Dr. Alix Schnibben and Dr. Barry Barnes. Dr. Alix Schnibben obtained her Doctor of Pharmacy from the South Carolina College of Pharmacy at the University of South Carolina in 2011 and completed her postgraduate Year 1 Community Pharmacy Practice Residency at Virginia Commonwealth University in 2012. After her residency, she became a pharmacy manager with Walgreens and served as market lead for wellness programs. In 2014, Dr. Schnibben took a position at Fort Stewart in Hinesville, Georgia, as a clinical pharmacist specializing in disease state management, polypharmacy, and tobacco cessation. Dr. Schnibben transitioned in 2016 to St. Joseph Candler Health System for medication management in Savannah, Georgia, as clinical pharmacy specialist in ambulatory care. With SJCHS, Dr. Schnibben worked in the anticoagulation clinic and was embedded in primary care clinics to provide direct patient care. She established SJCHS PGY2 in ambulatory care and was the residency program director. In 2019, she transitioned to Northeast Georgia Physicians Group as an ambulatory care pharmacist working to establish ambulatory pharmacy services. She was promoted to Director, Clinical Quality and Ambulatory Pharmacy Services, and in her current role, she focuses on population health, medication access, medication and immunization safety and education, and direct patient services provided by pharmacists. Dr. Schnibben is board certified in ambulatory care, pharmacy, and a tobacco treatment specialist. Dr. Schnibben was awarded the Georgia Medical Society Healthcare Hero Award for Tobacco Cessation Education in 2016 and the Georgia Society of Health System Pharmacists Pharmacoeconomics Research Award in 2019. I would also like to introduce Dr. Barry Barnes, who is the clinical pharmacist specialist in infectious diseases and antimicrobial stewardship. After graduating from Duquesne University in Pittsburgh, Pennsylvania, he completed his PGY1 residency at the University of Virginia Health System. Dr. Barnes started his pharmacy career at Dartmouth-Hitchcock Medical Center, practicing critical care prior to transitioning into infectious diseases in 2010. He joined Northeast Georgia Medical Center in 2016, and he serves as the pharmacy specialist for the Antimicrobial Stewardship Program and the program director for the Northeast Georgia Medical Center Pharmacy Residency Program. Let's welcome our speakers today.
All right. Thank you so much. This is a two-person presentation today for continuing education, focusing on two topics. So the first part will be decoding the clock, how long is too long for outpatient antibiotic therapy. Again, this is starting our journey in the ambulatory side of really focusing on antimicrobial stewardship. Myself nor Barry have anything to disclose. So there's two objectives for my part of the presentation today. Understand evidence-based guidelines for determining the optimal duration of outpatient antibiotic therapy for common infections, as well as identifying the risk and benefits of antibiotic treatment durations to minimize overuse and improve patient outcomes. We understand that using minimal effective antibiotic therapy durations is a component of antimicrobial, or sometimes referred to as antibiotic stewardship. And that's important when we think about the increase of resistance across our country. I know that when we think about antibiotic stewardship, especially on the ambulatory side, that it can be a harder conversation to have with patients because we don't have as much of a formulary to control or as much oversight when a patient is in the ambulatory side as compared as when they're in the inpatient side. So when we think about why duration matters, it's really important to think about some key components of antibiotic stewardship. We know that is a systematic effect to promote the appropriate use of antibiotic. This includes prescribing the right antibiotic at the right time for the right duration. Overuse and misuse of antibiotics can contribute to antimicrobial resistance, leading to longer hospital stays in the future, more complex infections, and higher mortality rates. So we have to think about focusing on areas that we can impact, which is excessive antibiotic use on resistance pattern and the role of duration in managing resistance and improving patient outcomes. So when we think about some of the key points to drive home is our goal is to balance efficacy of the treatment with minimizing the unnecessary exposure to antibiotics. But we know with more antibiotics, that leads to more adverse reactions, which then can lead to C. diff or patients not taking the full medication because they don't like that it upsets their stomach. So overuse of antibiotics can contribute to the resistance, but we found that shorter durations can be effective at minimizing those side effects, which means the patient is more likely to take the full duration of their medication, have their infection cleared, and not have to have any secondary treatment because the first one worked. Longer courses we know are associated with C. diff. So thinking about the general principles of duration of antibiotic therapy. So there's multiple guidelines for each type of infectious process, but a lot of them have some common denominators. One, those being the effective dosing varies about the infection type severity, but we have to think about those patient factors because a patient could have COPD or uncontrolled diabetes, and that could lead to a longer duration of therapy. Or think about our younger pediatric populations when we think about a treatment of acute otitis media. It's going to be a longer duration for those younger children, less than 2, than those over the age of 2. So shorter durations have bound to just be as effective as those longer durations. And overuse of antibiotics increases the risk of resistance and adverse effects. We're not going to talk about today about, appropriate selection or when you should actually use the treatment. We're talking about if you've already selected the opportunity to treat, what should our duration be and how should we have those conversations about factors that affect duration of treatment. We know that antibiotic stewardship really emphasizes de-escalation and discontinuation of antibiotics when possible, and really thinking about the clinical progression of a patient and using cultures to help guide us. Well, other parts that affect that duration of therapy are things like age. So pediatric population versus elderly versus pregnant, may have different treatment requirements for duration. Comorbidities also, diabetes, chronic conditions such as COPD and other lung conditions, an immunocompromised state. Thinking about renal and hepatic function, that does affect the metabolism and elimination of the antibiotics, therefore affecting the duration. Another thing to take into account is patient adherence. We know shorter courses may improve that patient experience, leading to better compliance, leading to less complex regimens, leading to the clearance of that infection without having them to come back to the doctor and have another visit, or even a hospital stay because the first one was not effective or too complex for the patient to take. So now really diving into those most common evidence-based guidelines for common infection. The first one we're going to look at is acute uncomplicated cystitis. So optimal duration of antibiotic therapy for uncomplicated urinary tract infection in older women was looked at in a double-blind randomized controlled trial in 2004. The proportion of patients with bacterial eradication at 2 days after treatment was 98% in the 3-day group and 93% in the 7-day group. When we look at that, the frequency of adverse events, including drowsiness, headache, nausea, or vomiting, and loss of appetite was significantly lower in the 3-day group. So even though when we look at table 2 of looking at 2 days efficacy of the treatment when they're on a 3-day or a 7-day regimen, we see about the same when it comes to symptom improvement and bacterial eradication. But what's really important is when you go down to table 3 is when we're looking at the side effects. Those are more associated in the longer duration. So something really to take into place is that the majority of the patients with UTIs, that shorter duration does show that the patient gets better. They have less side effects. Now, depending on the treatment that you choose, the duration may be a little bit different. The population can be a little bit different. So, that 3 days is commonly more for, uncomplicated, women who have UTIs. And so when we think about, there's a JAMA study in 2021 that looked at effectiveness of a 7-day versus 14-day antibiotic therapy on resolution of symptoms among afebrile men with urinary tract infections. And what they found is that a 7-day course of Cipro or trimethoprim sulfamoxil as an alternative to a 14-day course in treatment, could be, support findings that you could do that shorter duration of the 7-day versus the 14 days in men. But again, there's a lot of information about treatment and looking at the full patient. So, some patients may need that longer duration. But when we're thinking about the uncomplicated in women, that 3-day has a lot of clinical evidence to show that the shorter duration have similar efficacy, as well as lower chances of those symptoms of adverse reaction. Now, turning our next to community-acquired pneumonia. So we know a lot of our common pathogens here is that Streptococcus pneumoniae. I know we've sent a lot of information around about, choosing the correct treatment for this recently, and kind of, making sure that our antibiograms were lined up to make sure that our providers had a lot of information around that. There was a trial in 2023 in BMJ Open, which was looking at the optimal duration of antibiotic treatment for community-acquired pneumonia in adults. It was a systemic review looking at duration, effect, and it was a meta-analysis. And what it found is when it looked at 2,399 patients with a mean age of 61.2, and 39% of those were women. What they found is that a shorter duration of 3 to 5 days probably offers the optimal balance between efficacy and treatment burden for treating community-acquired pneumonia in adults if they achieve clinical stability. However, there is a small population of the patients that may require a little bit more because they were at moderate or high risk for complications. So there might have been some bias in the results related to that. In 2016 in JAMA, there was a duration of antibiotics treatment and community-acquired pneumonia. It was a multi-centered randomized clinical trial. And the main outcome measure that they found was looking at clinical success at days 5 and 10 using an 18-item CAP symptom questionnaire. And what they found is that the higher scores indicated more severe symptoms. So looking at the intervention group, those that had lower scores were more likely to respond to the shorter course of day 5 treatments comparative to the people that had more symptoms may need a longer treatment course. And then, we kind of had the IDSA guidelines that came out in 2019 that really align with using that shorter duration and being more selective on your antibiotics when it came to empiric treatment, and making sure that you covered correctly for that patient to reach the clinical outcome, which is feeling better. Looking next at pharyngitis. So this is one that's been a lot of hot topic in the ambulatory setting lately with the increased amount of strep that we're seeing, and trying to decide, what is your primary antibiotic that you're going to choose versus secondary if they have the penicillin allergy. And that's been a hot topic here. But we did have a very in-depth conversation among the providers on the ambulatory side for duration of therapy when we were actually putting together our duration of therapy as well as our evidence-based guideline about the treatment of strep pharyngitis, and looking at whether patients would respond better to the a shorter course. And when we did a lot of looking here at several guidelines and things, we found a lot of evidence to support maintaining that 10-day course. There was a article published in Antibiotic in 2020, which was looking at short versus long-acting courses of antibiotic treatment in acute streptococcal pharyngitis. Again, it was one of those large systematic reviews and meta-analysis of those random controlled trials. And overall, what they found is looking at the primary outcome is that the majority of patients were treated with 10 days of therapy had a better response using a 10-day course of penicillins and amoxicillins compared to a shorter course with cephalosporin. So it then goes back to using that full 10-day course. Not only does it get us the clinical outcome you're expecting, you have a low risk of adverse effects, but comparative to those shorter courses, which did not have a clearance. So the recommendation here is that 10 days duration. Moving on to skin and soft tissue infection. This is a very large, broad category. When I was doing a lot of deep dive into looking at common infections associated with skin and soft tissue infections, relied a lot of looking at the pathogens that caused it, what exactly we were looking at. Was it cellulitis versus other skin and soft tissue infections? And, found that it was really about what was the pathogen, where was the location, and what were the symptoms that would kind of to guide your treatment of choice versus your duration. And looking at both the IDSA guidelines in 2014, and then also looking at a study entitled Comparison of Short Course 5 days and Standard Duration 10 days course of uncomplicated cellulitis. And what they found here is that in patients with uncomplicated cellulitis, 5 days of therapy with levofloxacin appears to be as effective as the 10 days of therapy. So read into a lot of individual articles about multiple types of skin and soft tissue infections. And again, a lot of them lean towards the course of that 5-day course, but some patients, depending on what you're looking at as severity, might need to lean towards that 10-day course. So anywhere between that 5 and 10-day course, and then after that, need to really reevaluate and possibly getting wound care involved if that is needed. To kind of help that patient if they're outside that standard course of treatment. The next one to think about is otitis media. A lot of the articles I found here in guidelines were more related to the pediatric population comparative to the adult populations. But the American Academy of Pediatrics recommends the usual 10-day course to be reserved for patients that are less than 2 years of age. Thus, children older than 2 or with mild symptoms should receive the shorter course of duration of 5 to 7 days. However, they did put in their guideline that if a child is over the age of 2 but has severe symptoms, bilateral infection, having high fevers, that patient may be a good candidate to receive that 10-day course and really reserving that shorter duration for your children over the age of 2 with milder symptoms could be adequate. Looking at, there is some more support in short antimicrobial treatment for acute otitis media in young children, which was in New England Journal of Medicine in 2016, in which they had this table 2 here, which summarizes the results looking at index episodes of acute otitis media. Clinical features were observed in a greater percentage of patients treated with amoxicillin claviconic for 5 days than those treated for 10 days. And so what looking here is when they took a deeper dive into a subgroup analysis, they found that the patients who, again, the 5-day course worked better with those who were older and had less clinical symptoms comparative to those younger patients less than 2 that had or older than 2 that had more severe clinical symptoms. So overall, again, this trial does support what the American Academy of Pediatrics has put out most recently about the treatment of acute otitis media. So again, balancing your patient's demographics and your antibiotic selection as well as that duration, make it very patient specific to make sure we're kind of using shorter durations of therapy when we possibly can. So there was a trial that came out in 2017, looking at the duration of outpatient antibiotic therapy for common outpatient infection. And what they looked at was prescriptions associated with pharyngitis, sinusitis, acute otitis media, CAP, skin and soft tissue infection, and acute cystitis using the National Disease and Therapeutic Index from 2017. Using the private practice sample and office-based physicians reporting quarterly on all patient visits for 2 randomly selected consecutive workdays. They looked at a sampling of these visits. And what they found was 2,889 sampled antibiotic prescriptions from visits that met their inclusion criteria, translated to a national estimate of 31 million antibiotic prescriptions from private office practices, including specialty. 11% of these estimated prescriptions were azithromycin, therefore excluded in the duration analysis. And so their study, again, found that clinicians frequently defaulted to 10 days of duration, even when guidelines recommended shorter durations, potentially exposing patients to an unnecessary long antibiotic therapy durations for many common conditions. Specifically, compliance with the recommended duration of therapy could be improved for sinusitis and community-acquired pneumonia, cellulitis in all ages, and acute cystitis in women from 12 to 64. So there needs to be an increased focus on duration of antibiotic therapy for those common conditions to reduce the unnecessary exposure to antibiotics in the ambulatory side. So even though they had the guideline recommended things, when they looked into the database, the majority of people still defaulted to that 10 days. So that's concerning when we think about exposure and resistance. So another trial looking at optimizing antibiotic exposures by customizing the duration of treatment for respiratory tract infections based on outpatient needs in primary care. This again was looking at primary care antimicrobial stewardship programs. We know that they have limited success in reducing antibiotics use, promoting the need to search for new strategies, and finding a way to convince general practitioners to resist antibiotic prescriptions amid unnecessary or patient demands usually poses a significant challenge. Despite common practices, standard durations for common infections need a little bit more support, a little bit more education to really help providers be able to stay up to date on the literature. Contrary to common belief, extending antibiotic treatment beyond the resolution of symptoms does not seem to prevent or reduce antimicrobial resistance. Shortening the duration of antibiotic therapy has shown to be effective in mitigating the spread of resistance, particularly in cases of pneumonia. So it's really important we think about that, even though on the ambulatory side, you have that patient in front of you, they're having a shared decision-making conversation. It's really important to, if you choose to treat with antibiotics, that we choose the best duration for that patient, again, thinking about their risk of resistance in the future. So overuse for antibiotics can lead, and extended use can lead to resistance, increasing resistance when antibiotics are overused or used longer than necessary. Focusing on the narrowest spectrum for the shortest duration is key. Side effects such as GI issues, including C. diffs, allergic reactions will more likely happen with prolonged therapy. You got to think about the cost. Extended therapies can increase healthcare costs and burdens for patients with unnecessary treatments, can keep them out of work due to side effects. And not only is it treatment cost to the patient, but cost to their employer and a cost to the health system. So again, making the most appropriate selection. When thinking about balancing the risk and the benefits, the risk of overuse, risk of development leading to treatment failures, when we think about resistance, disruption in the normal microbiota, increase in healthcare costs and patient morbidity, benefits of optimal duration, shorter courses reduces resistance, increases adherence as well, fewer side effects, and most cost effective. So thinking about that 7-day rule, that's a common myth that we hear from patients. Oh, I need to take everything for 7 days, and some for some. We saw in that 2017 meta-analysis, a lot of people still deferred to a 10-day rule. Antibiotics, that's a myth that they have to be prescribed for 7 to 10 days for all infection. The fact is many infections can be treated with 3 to 5 days, particularly with appropriate antibiotics. And also shorter therapy is often as effective. So again, having those shared conversations with your patients. Having a decision-making framework when you have the patient in front of you, think about the key considerations here to select the best duration. What is the type of infection? What is the severity? What does the patient look like in front of you? Like, what are their comorbidities, their age, their underlying conditions? What is their clinical improvement? Do you expect them to get better without antibiotics? And really having that conversation about delayed treatment. Evidence shows that shorter durations of therapy is very effective for common infections. Lots of guidelines as well as clinical trials support the 5 to 7 days versus those longer courses. So how can we think about minimizing overuse? Education, such as today, talking about it through continuing education, talking about it with your peers, with your patients, making sure that they understand the risk of overuse and why we want to do shorter courses, or helping them understand why we don't want to do the antibiotics. Discuss when antibiotics are necessary and when they are not. Thinking about antibiotic stewardship, utilizing our program to, for the most appropriate prescribing, implementing clinical decision tools for infection management. And strategies for optimizing antibiotic duration. Follow the guidelines. There's lots of them out there staying up to date. I know that ones do not publish as frequently for infectious processes if comparative to some chronic disease states. But there's lots of articles out there that can help you pick the best duration for your patient. De-escalation of therapy, reduce the spectrum of antibiotics based off the culture and sensitivity. Discuss, share decision-making conversation with that patient, balance it with safety and benefits, and talk about the risk of overuse and what that could mean for the prescribed course. And then, provide education about resistance, not only to the patient, but to your peers. So for conclusion today, evidence supports shorter courses of antibiotics for many common infections. We want to balance efficacy of the treatment to minimizing the side effects. We want to utilize those evidence-based guidelines and clinical judgment to select the correct duration. Proper duration of antibiotic therapy is essential for both how the patient feels, how quickly they get better, as well as reducing the resistance. Adherence is something we should always put into our mind as we're selecting the therapy for that patient. If we know that patient has a history of non-adherence, we may want to choose something that's a shorter duration with least number of times per day they need to take it in order to get the same clinical outcome, because they're more likely to continue to take their therapy for the full treatment course and have a resolution. Physicians should tailor antibiotic therapy and duration based off infection type, patient factors, and evolving clinical evidence. And I will turn it over to Barry now.
So I'm going to cover a couple topics that I've seen some inconsistencies in treatment lately. I also have no disclosures. So we're going to summarize some of the changes in microbiology reporting and some shifting terminology within the literature. We're going to review 2 commonly reported beta-lactam inactivating enzymes, and then determine the evidence-based approach to treat these resistant organisms. So I'm going to start with a patient case. And we have a 44-year-old female who presented to clinic with nausea and vomiting for a couple weeks, fever for a day, no appetite. She ended up being diagnosed with pyelonephritis and with bacteremia. She was started on ciprofloxacin. Come to find out that she has multiple renal abscesses. She has a past medical history for rheumatoid arthritis as well, so she's on a average dose of methotrexate. Her blood cultures grew E. coli. It was, even though she was started on the Cipro, it was intermediate to Cipro, and it was ceftriaxone resistant. So the first poll question is going to ask, other than ertapenem, because as an antimicrobial stewardship approach, we try to use carbapenem-sparing strategies when possible, what would be an effective agent, if any? I have a second case for you. So we have an 83-year-old male who presented to the ED with reports of shaking, chills, and rigors. He was admitted to the ICU with septic shock, secondary to a urinary tract infection complicated by bacteremia. He was started on vancomycin and cefepime. He has a history of recurrent UTIs, chronic indwelling Foley catheters, and Alzheimer's disease. Out of his blood, he grew Enterobacter cloacae complex, with resistance to cefazolin and cefoxidin, and it was intermediate resistance to ciprofloxacin as well. So my question to you is, again, other than ertapenem, what would be an effective agent to treat this infection? Ceftriaxone, cefepime, pip/tazo, or none of the above? So I'm not sure my audience can see responses, so I'm just going to sort of go over them real quick. In the first question, 20% chose cefoxidin, 20% chose cefepime, 40% chose pip/tazo, and 20% chose none of the above. I close this current poll, and 50% chose cefepime, 13% chose ceftriaxone, 25% chose Zosyn, and 13% chose as treated. So we're going to come back to that later in the presentation. So when we talk about bacterial resistance, I like to break it down into 3 general buckets. Somehow the bacteria diminishes the intracellular concentration of the antibiotic. So it can basically not let the antibiotic in through the cell walls, or once it does penetrate the cell wall, it can basically pump it back out through efflux pump mechanisms. It can also modify the target. So if there's changes to the target site, the binding affinity of the antibiotic is greatly decreased. Therefore, it doesn't have the effectiveness that it had before. And then finally, it can inactivate the drug. So in that, we'll talk about beta-lactamase enzymes that break down the antibiotic. And there in the right-hand side, in the lower right-hand corner, you have the structure of penicillin. And you have beta-lactamase enzyme coming in, and it's basically going to hydrolyze or break up the penicillin structure into two different pieces that are ineffective as a whole. And we're going to talk further about the beta-lactamases because that's what I wanted to address today. There's a couple different ways to classify beta-lactamases, but the Ambler classification system is probably the most clinically relevant. In Class A, we have our extended spectrum beta-lactamases, or ESBLs. Those are very common in E. coli, Klebsiella pneumoniae, Klebsiella oxytoca. The most common family we see here in the United States are the CTXM ESBLs. They will hydrolyze or inactivate penicillins, cephalosporins, most of the time as trionam. To inhibit the beta-lactamase enzymes, we can use clavulanate or tazobactam. Class B has a zinc at the active site, so we refer to them as the metallo-beta-lactamases. They can be present on E. coli and Klebsiella pneumoniae as well. NDM is the most common family that we see. These are very difficult to treat. They pretty much hydrolyze all our beta-lactams with the exception of a very new agent called fitorakol. And then as trionam is stable as well, but technically it's a monobactam. Class C is our AMP-C beta-lactamases. These are actually a little bit more broad spectrum than our ESBLs. And these are in our Enterobacter cloacae, Citrobacter, Klebsiella aerogenes most commonly. They'll hydrolyze the penicillins and the cephalosporins. Tazobactam is a weak inhibitor. Otherwise, other inhibitors are in the newer agents, avibactam, vaborbactam, relebactam. But you'll note that cefepime is stable to the AMP-C beta-lactamase. And then finally, Class D is what we refer to as the oxas. Oxas can vary greatly. Simple oxas can maybe just hydrolyze penicillin, while other oxas are very broad spectrum and basically can hydrolyze all beta-lactams. And oxas are only really inhibited by avibactam. All our other newer beta-lactamase inhibitors aren't really effective. So from history on our ESBLs, so they first came to fame with an outbreak in the ICU in France in 1986. By the 1990s, papers were reporting that 25 to 35% of Club pneumo were ESBL producers. This caused a major problem for treatment with our second and third generation cephalosporins, because prior to ESBLs, our cure rates with our third generation cephalosporins, if the MIC was 8 or less, was like 95% clinical success. However, if it was an ESBL producer and the MIC was 4 to 8, we basically had a 90% failure rate. So we had to address this issue. And it really, at this time, it was more of a European issue. So the Europe's took a different approach than what the United States did. Europe basically lowered their breakpoints. So they called the MICs of 4 to 8 as resistant, while the US decided to keep the breakpoints the same, keep the breakpoint at 8 for ceftriaxone and ceftazidime, but we're going to screen to see if it's an ESBL producer. And if it's an ESBL producer, then we're going to call it resistant, no matter whether it tested susceptible or not. How do we do that? Most of the time we use phenotypic testing. Basically, we used here at NGMHS, we use Vitek, so we use the broth micro dilution. So you'll have you'll test the breakpoint or the MIC of, say, ceftazidime alone, and then you'll test the MIC of ceftazidime coupled with clavulanate. And if the MIC drops significantly, a few dilutions or more when it's in the presence of the clavulanate, then you know it's an ESBL positive organism. And we would report that with the susceptibility results as an ESBL positive organism. Now, since then, ESBL organisms are much more common than they used to be back in the 90s and early 2000s. And in 2010, CLSI joined basically the approach of the European approach and did choose to lower the breakpoints. So the ceftriaxone breakpoint changed from 8 all the way down to 1. And when they did that, they basically said, you don't need to perform the screening process anymore, and you just treat based on whether it's susceptible or resistant based on the new lower breakpoint. The problem was there was no FDA-approved way for us to test with the lower breakpoints, so we continue with the current process until about 2020. We finally were able to sort of implement the lower breakpoints, but infection control was also using enhanced precautions for ESBL infections. So we kept reporting the ESBL positive or negative. So on the left-hand side is what our clinicians have been used to seeing for years and years for an E. coli or Klebsiella pneumoniae that was ESBL positive or negative. We would report positive or negative. Today, because it's not recommended that we need to do ESBL screening for these organisms anymore, as long as we use the lower breakpoints, we have moved to that process. And a few months ago, we started reporting the E. coli's and the Kleb pneumoniae, similar to the susceptibility pattern on the right. So you can see the ceftriaxone resistance there, and that would essentially be your marker to know that this is an ESBL positive organism because it's resistant to ceftriaxone. Now, here today, we suppress the cefepime result because if it's an ESBL positive organism, the cefepime is likely to fail. We also choose to suppress the pip/tazo result, and we'll discuss why we need to do that here in the next couple slides. So the Marino trial was it was published in 2018 and was really supposed to solve the issue of whether we can treat ESBL organisms with Zosyn or not. So basically, this compared Zosyn versus carbapenem therapy for ceftriaxone-resistant E. coli and Kleb pneumo. We had 378 patients, and it was set up as a non-inferiority trial with a non-inferiority margin of 5%, and they were looking at 30-day mortality rates. And what they determined is basically Zosyn was not non-inferior to the carbapenem because it basically had a higher mortality rate at 30 days. So from this, we said, we shouldn't use pip/tazo for ESBLs. Now, what's behind the scenes now is after the Marino trial happened, they actually lowered the Zosyn breakpoints. The Zosyn breakpoint used to be anything less than 16 used to be considered susceptible. However, they changed that to less than or equal to 8. So we really don't know what effect these new breakpoints would have had on the Marino trial. So we still have a slight question about pip/tazobactam, but the consensus from IDSA guidelines for antimicrobial resistant gram-negatives is that for ESBL infections, meropenem and ertapenem are the preferred treatment options for infections outside of the urinary tract. And then at the end of this paragraph, I did include that after clinical response is achieved and susceptibility has been determined, you can de-escalate to Bactrim or ciprofloxacin, fluoroquinolone. So if we go back to the patient case, so this is a ceftriaxone-resistant E. coli, obviously a very complicated pylo case. I would argue that cefepime, Zosyn is not appropriate in this case, ceftriaxone not being appropriate in this case, and the appropriate treatment, basically the answer to the question should have been none of the above, and ertapenem was actually the only appropriate choice. So let's shift gears to AMP-C beta-lactamase expression. So AMP-C beta-lactamase is very, very complex to explain. I'll try to do my best. But AMP-C beta-lactamases are expressed by a lot of different organisms, but they're sometimes constitutively expressed. So previously, I've always had this in my head, it's plasma mediated. If it's in E. coli, if it's in Klebsiella pneumoniae or Pseudomonas aeruginosa, it's always going to be expressed in that resistance pattern you see on the susceptibility panel. You could trust it and treat it accordingly because it's always been expressed. Now, in other organisms, it's chromosomally mediated, and they can basically, you see a very benign susceptibility panel, but with the exposure to a beta-lactam, that organism might start kicking out AMP-C beta-lactamase unexpectedly. And there's basically two different common stages where you have stable derepression or inducible derepression. And I'll do my best to explain that simply. But basically, the organisms that have these chromosomally mediated AMP-C beta-lactamases used to refer to the space or spice organisms, but now refer to them as the heck yes organisms. So these are sort of space and spice being outdated acronyms, because everybody was always fighting over what the P stood for. Was it Providentia? Was it Pseudomonas? What does the I stand for? Consensus now is heck yes is our acronym. So the heck yes organisms are Havnia alvei, Enterobacter cloacae, and Citrobacter fundii, and then Klebsiella aerogenes. They make up the heck version of our heck yes organisms. The yes side is Yersinia enterocolitica, Serratia marcescens, and then Providentia and Morganella didn't even sort of make the acronym. But I want to sort of differentiate the heck organisms and the yes organisms, because clinically they're a little bit different. But just a sort of basic background on, and I'll try to explain this mechanism as simply as possible, but you can have a population on an Enterobacter infection that does not produce AMP-C beta-lactamase at all, and you don't see much resistance at all. That's actually not that common, but there's something defective with the pathway. On the other side of the other extreme, you can have mutations within the organism where it always kicks out AMP-C beta-lactamase at high rates, and you see high resistance patterns. Most of the organisms lie in the middle somewhere. So there's kind of like this normal state where there's no beta-lactam antibiotic exposure, and there's hardly any AMP-C beta-lactamase produced because it's not really under threat. If you expose it to a beta-lactam, it'll start kicking out AMP-C beta-lactamase to attack the beta-lactam antibiotic. But within certain populations, maybe 1 out of every 100 Enterobacter will have a mutation where if you expose it to the beta-lactam antibiotic, it will kick out a whole lot of AMP-C beta-lactamase, basically a hyper expression of beta-lactamase, and it will cause a much more high-level resistance pattern. And when those are within the population, you'll see failure if it occurs. A couple factors that come into play is, depending on the antibiotic that I choose, might determine how much AMP-C beta-lactamase is induced, and then how susceptible is the antibiotic am I using to that AMP-C beta-lactamase. So I cite carbapenems as a good example. So if I use imipenem to treat my Enterobacter infection, it will induce AMP-C beta-lactamase at a high rate, but it's completely stable to the beta-lactamase, and you will be successful using imipenem. On contrast, if you use a cefazolin or ampicillin, it will induce AMP-C beta-lactamase at a high rate, but then the hydrolysis rate is also very high, and you'll likely see failure. Cefepime is unlikely to induce AMP-C beta-lactamase, and then it's fairly resistant to hydrolysis as well, so that's why we see success with cefepime. Piperacillin tazobactam is kind of in the middle as an inducer, kind of in the middle of a hydrolysis rate, because the tazobactam is somewhat effective as an inhibitor, and that's why sometimes we see success and sometimes we don't. This paper by Coleman and College kind of sort of outlines that as quite nicely. And basically what they did is they induced the AMP-C expression, and then they tested susceptibilities. And you can sort of see the heck organisms, which are in the red box, the Enterobacter cloacae, Klebsiella aerogenes, Citrobacter fundii, and the Havnia alvei. When they were induced, the ceftriaxone susceptibility rate, the ceftazidime susceptibility rate was near 0, and the piperacillin tazobactam susceptibility rate was down less than 30% for all those. And then if you look at the other side, the yes organisms, so the Serratias, the Morganellas, even with induction, the piperacillin tazobactam susceptibility rate still was fairly high. The Marino 2 trial was supposed to answer this question for us to determine whether we really could use pip/tazo, or we needed to use meropenem for bloodstream infections caused by our HEC-S organisms. But it really only included 72 patients. It didn't really detect a difference in our composite endpoint. But then we look at the organisms within the study, and half of them were the yes organisms, where we know we kind of still have activity. The other half were the more resistant HEC organisms. But basically, the trial was watered down, and it didn't include very many patients. Since then, there was a retrospective study in 575 patients, and they looked at patients with pneumonias and bacteremias. And they basically looked, were you treated with a third-generation cephalosporin like ceftriaxone? Were you treated with the standard of care of a cefepime or a carbapenem? Or were you treated with Zosyn? And when they looked at all-cause mortality at day 30, they didn't see a difference in all-cause mortality. When they looked at treatment failure due to AMP-C overproduction at day 30, that's where we did see a difference. So if you look in that high producers, the Enterobacter, Klebsiella, Aerogenes, Citrobacter fungi, they're in the top row there. Overall, they saw a 4% failure with cefepime and carbapenem, and then they saw a 12% failure with Zosyn. If you look at the lighter blue dots down below, that's the Serratias and the Morganella, are yes organisms. Cefepime and carbapenem had a failure rate of 1%. Pip/tazo had a failure rate of 6%. Now that was statistically different, but again, failure rate was only 6% in pneumonia and bacteremia, which is fairly positive for pip/tazo. But that's basically the rationale for the consensus document, saying that we shouldn't use third-generation cephalosporins because those failure rates are fairly high if you're treating an organism that has the ability to produce AMP-C beta-lactamase. And then pip/tazo is not suggested for the treatment of invasive infections caused by Enterobacteriales at moderate risk of clinical inducible AMP-C production, or HEC organisms. So if we go back to case number 2, other than ertapenem for this patient in septic shock, what would be an effective agent? We know we can't use third-generation cephalosporins, so ceftriaxone is out. We know that if this is an invasive infection, which septic shock, I would argue, is definitely there, then we shouldn't use pip/tazo either. So the correct answer here, or in my opinion, is the cefepime. So in summary, we have some new terminology now. So we don't really sort of refer to it as ESBL positive or negative E. coli or ESBL positive or negative Klebsiella. It's really ceftriaxone resistant E. coli or ceftriaxone resistant Klebsiella or ceftriaxone resistant Proteus. And you see the general recommendations there. I'm not going to go down through them, but I'll go down to the last bullet point on that side. So for infections outside the urinary tract, for ceftriaxone resistant E. coli, Klebsiella, or Proteus, carbapenem is our primary therapy choice. Now, with that being said, after clinical response, we can de-escalate to oral Bactrim or oral Cipro. If we flip over to the other side to address our HEC-yes organisms, if it's our yes organisms, so our Yersinia, our Serratia, our Providentia, or Morganella, we can treat those as deemed susceptible with our non-beta-lactam choice of antibiotics. But pip/tazo is probably going to end up with a good outcome, and as we've seen in some retrospective studies at least. If it's our HEC organisms, they're more likely to have those mutations where to kick out high levels of AMP-C beta-lactamase, and therefore pip/tazo is not okay, and cefepime or ertapenem would be our primary agents of choice. And again, the same goes, once clinical success is achieved, if Cipro is susceptible, if Bactrim is susceptible, we can de-escalate to one of those agents. So that's my final slide, and I think we can take questions.
I see a comment from Dr. Manapali. She says, great presentation, Barry and Alex. Thank you so much.
Yeah, so she says, can I share where the resources for antibiotics guidance are available? And I can describe where that's available. So when you're in a patient in EPIC, so for our providers, There's a sidebar summary on the right-hand side of the screen. And there in the primary report, there's a, it's called antibiotic guidance link. And if you click on that link, it'll open up the resources that we have vetted and approved through antimicrobial stewardship committees. And there's 2 relevant documents. Actually, for this talk, 3, there's our duration guideline that's in there for our inpatient duration recommendations. I know Alix has a separate one for the outpatient, but there's also the treatment guidance for Enterobacteriales and a de-escalation guide for Enterobacteriales infections as well.
So that should wrap it up. Thank you, everybody, for attending.